Do you need a DAT scan or a skin biopsy to make the diagnosis of Parkinson's disease? In most cases, the short answer is no. If you want to know more about this topic, watch this video. My name is Dr. Zayas. I am a neurologist and internist specialized in movement disorder. It is very important for you guys to understand that still in 2023, 2024, the diagnosis of Parkinson's disease is still clinical. Yes, the technology has advanced significantly during the last 10 years, but still the diagnosis is clinical and the test, the imaging study cannot replace a good trained clinician. I'm pretty sure you guys think how doctors are making the diagnosis of Parkinson's disease just observing patients walking the hallway and performing some movements. Well, because the diagnosis is based on observation and putting pieces of the history together. This is how you make the diagnosis, the clinical diagnosis of Parkinson's disease. However, the final diagnosis, only the pathologist will make the final diagnosis based on the autopsy, which means when you die, the pathologist will take a look with a microscope, a look of a piece of your brain to try to identify those abnormal proteins that we find in patients with Parkinson's disease. This is how you make the final diagnosis. Yes, I understand that this sounds scary, but let me tell you that movement disorder fellowship trained neurologists are pretty good making the diagnosis of Parkinson's disease. And I think better now because we have more technology, we can use a DaT scan and skin biopsy to help us with the diagnosis as well. Making the diagnosis of Parkinson's disease during the first 5 years can be sometimes difficult because there are many things that looks like Parkinson's disease, but they are not Parkinson's disease. Something similar, but they are not Parkinson's disease. Let me show you some data so you can believe me. This study published in 2016 in the Green Journal Neurology, they evaluate 20 studies. The majority of them using pathological examination, I mean biopsy as a gold standard. They found that 80% of the patients were diagnosed correctly. 20% of them approximately were diagnosed incorrectly. The diagnosis accuracy improved when the diagnosis was made by an expert in the area, a movement disorder specialist, as expected. Another study, this one published in 2014 in the same journal, showed that the accuracy of making the diagnosis during the first 5 years is approximately 50%. It's like flipping a coin. After 5 years, the diagnosis accuracy improved to close to 90%. Now, I have to say that these two studies were based on prior diagnostic criteria for Parkinson's disease. I'm pretty sure if they use the relatively new criteria published in 2015, the diagnosis accuracy will be better and probably a little bit more if we add the skin biopsy data. Sometimes our best friend is just time, but frequently we don't have the time or the case is so complex because they have many overlapping features that we need more testing, such as a DaT scan or a skin biopsy. Watch the video of early symptoms suggesting Parkinson's disease because that might help you to understand how we make the diagnosis of Parkinson's disease. The link will be below the description of this video. The bottom line is you do not need a DaT scan to make the diagnosis of Parkinson's disease. In some situations, some patients, it might help significantly, but not in every patient. There are many reasons to order a DaT scan. I have another video explaining that. The link will be in the description of this video. Now, remember, when we order any test, you need to correlate with the patient. Things need to make sense. Otherwise, it's useless. They are useless. Now, if you have a patient who was diagnosed by a movement disorder, fellowship trained neurologist, and you are responding to levodopa, adding a DAT scan is not going to change too much. You're already responding, most likely the diagnosis is Parkinson's disease. So it will give you little information, if anything. So that's how I think these are waste of time and waste of money. To order a DaT scan in a patient who is responding to levodopa very well. So you don't need that. There are some situations that you really need a DaT scan, and I will give you the most common one. And this is very common. I see this a lot in the clinic, is when you have a patient with symptoms suggesting Parkinsonism, such as slow movement and stiffness, plus minus resting tremor, and the patient is taking a medication that blocks dopamine. If you take a medication that blocks dopamine, you will look, or you might look like a patient with Parkinson's disease. In other words, there is no way I can differentiate clinically between a patient with drug-induced Parkinsonism and a patient with Parkinson's disease. They look very similar. There are few ways to differentiate, and is number one, stopping the medication, and we need to wait months, but many patients cannot stop this type of medication, or proceeding with the DaT scan, or proceeding with the skin biopsy. A DaT scan will easily differentiate between a patient with primary Parkinsonism, such as Parkinson's disease, but it's not going to differentiate between many of the Parkinsonian syndromes. And also a biopsy can differentiate between a patient with primary Parkinsonism and drug-induced Parkinsonism. But it's not going to differentiate between the conditions that I will show you later that can give you a positive biopsy. So it's not going to help you with that. Now, another reason to do a DaT scan is when you have patients with many overlapping features or many co-founders, as I described before. For example, a 75 years old or 85 years old patient with significant arthritis. Very difficult to make them do the movement, the testing that we typically perform in the clinic. So there are many co-founders, and sometimes having an objective test proving that you have dopamine pathway deficiency helps significantly. This is another reason to proceed with that DaT scan. Another indication to proceed with a DaT scan is when you have a patient, for example, a patient with many years with action tremors, diagnosed with essential tremor, but lately the patient is developing a different type of tremor. And you are not sure because there are many overlapping features, and the patient already has significant walking issues, which will be like frequently multifactorial. So you are not sure. So this is another example of proceeding with a DaT scan, actually approved by FDA for that particular reason when you have patients with overlapping features between essential tremor and Parkinson's disease. Another reason is when you have a patient you are suspecting Alzheimer's disease, so a patient that looks like an Alzheimer type of patient, but at the same time, the patient is having some features suggesting Lewy body dementia. So a DAT scan might help you to identify those patients with Lewy body dementia as well. And remember, to make things more complex, many patients have a combined process. When I say a combined process, they actually can have Alzheimer's disease and Lewy body dementia at the same time. And the only way to be sure about that is with autopsy. When the patient dies and the pathologist check a piece of brain in the microscope, and the pathologist can see the abnormal proteins on those patients, and they are the one that give you the final diagnosis. Now let's talk about what involved getting a DAT scan. Try to watch this video by the GE Healthcare describing the DAT scan. Very nice video. The first thing I have to tell you is you need to make sure that you are not taking a medication that might interfere with the visual inspection of the DaT scan. And the list of this medication will be here, okay? There are many medications that might affect the visual interpretation of the DaT scan, which means that you need to tell your doctor that you are taking these medications. Otherwise, the test might be positive, but will be a false positive test because you are taking this type of medication that need to be tapered down even a week or sometimes 8 days, 9 days, 10 days before the test. Otherwise, you are wasting your money and the time. So make sure that you have a list of your medication with you always and let your doctors know about your medications. 1 hour before the test, you will receive something to drink. And I'm talking about iodine to protect your thyroid gland from the nuclear medicine. Then you have to wait approximately 45 minutes to receive the actual injection of the medicine, the nuclear medicine. Then you have to wait approximately 4 hours, 3 hours, depend the center, to actually get the scan. You have to be in this machine approximately 30 minutes. There is a machine will be very close to your head, and you need to remain still. By the way, this is a very safe test. One of the common side effects is a dry mouth after the test, and this is why we recommend you to drink enough water, plenty of water before the test. Another thing I want to tell you is the amount of radiation that you receive is significantly lower than a CT of the head. Let me show you what a normal DaT scan looks like. When you are learning something, you first need to learn what a normal looks, and then you see the abnormal. So here you see the normal DaT scan with the coma shape, right? Now, in patient with Parkinson or any other primary Parkinsonian syndrome, you will see that there is no coma shape. So it looks different. Look at this, looks different. Even the background is different. So you see here the different color, and here no color here. So because the background is also affected. So this is a patient with Parkinson's disease. Now I have to tell you that sometimes it doesn't look like this. This is very clear, very straightforward. Assuming that the patient is not taking any medication that affect the interpretation of the study. I'm assuming that. Now, sometimes the changes are so mild that you are like in a gray zone. And this is when you can have errors. So that's why you have to be careful with interpretation. And sometimes it's very difficult, even for radiologists fellowship trained in nuclear medicine, because this is a test which is basically visual. It's visual. Now, there is a software that help you with some numbers, but still many centers, they don't use that. For example, in my center, we just use visual inspection. Now let's talk about scene-1 test, which is the skin biopsy. First of all, we need to understand that the abnormal protein in patient with Parkinson's disease is not just located at the level of the brain, it's also located in multiple organs. This is why Parkinson's disease is a multi-systemic disease affecting multiple systems, not just the brain. The protein that I'm talking about the name is alpha-synuclein. Alpha-synuclein, you will see here. Now, when this protein is not working well, when your body, people with Parkinson, develop aggregations of this protein is when you start having problems. So because the protein cannot mix well, becomes insoluble. And this is when you start having issues. And this is the marker, the pathological marker for patient with Parkinson's disease, but not only Parkinson's disease, also something similar that we call dementia with Lewy body as well. Now, we are not sure if this abnormal protein is just a bystander or is the main problem in Parkinson's disease. This is a very controversial topic in our field. The point here is that we can detect with excellent accuracy this abnormal protein, and when present, it indicates that you have either Parkinson's disease, multiple system atrophy, dementia with Lewy body, REM sleep behavior disorder, which is acting out during sleep, or something that we call pure autonomic failure. Those patients that the blood pressure drop significantly when they stand up. They have what we call orthostatic hypotension. I have a video about that. So basically, we have 5 diseases that can have abnormal scene-1 test. This is why it's so important to correlate with the patient, not just ordering tests in patient without having a clinical correlation. The company that provide this skin biopsy scene-1 test is this one. This is the name of the company, CND Life Science. Check the website. And there is a lot of information here, and they claim that the sensitivity and specificity is more than 95%. I personally have question about the 95% sensitivity. And as I say before, these are the 5 diseases that can give you, and they're supposed to give you, a positive skin biopsy, including Parkinson's disease. Another question that I get is if whether this test is covered by the medical insurance. Now, in US, in United States, the answer is yes. I don't know in other countries, but in US, the answer is yes, the majority of the time. You need to make sure that you receive a letter indicating your out-of-pocket amount of money. And I will tell you more than 95% of the time, the out-of-pocket is 0, okay? There are some patients that they have some type of co-payment, but that might vary. So make sure that before allowing the doctor getting a biopsy on you, you have the letter indicating that the skin biopsy was approved and your co-payment is 0, okay? Do you really need this test? And this is a more complex question because it depends on many factors. You need to ask yourself the following question. Number 1, are you going to change your management with the results? That's the first question that you need to ask yourself. Do the results help you to know whether you qualify for clinical trials? That's another important question to answer. Number 3, are the results going to help you to accept the diagnosis, giving you peace of mind in order to move forward, to improve your quality of life? That's another important question. And this one, is the insurance covering this test? And if not, can you afford it? And the last question that you need to ask, are you considering deep brain stimulation, which is actually an invasive procedure with potential permanent side effects, and the result will affect the decision to go or not to go to surgery, or even the deep brain stimulation target. Now, the last question that we are going to discuss is how we perform this test, right? How we perform this procedure. Very easy to perform. Take me no more than 8 minutes. The first thing to do is just to clean the area that you are going to get the biopsy. I don't like to use this position because many of my patients, I will tell you, more than 50% of the patient I cannot get this position, prone position. So I typically get the biopsy in sitting position. So this is the 3 area. The first one is the back of the head. Then you have a 10 centimeters about the lateral aspect of the knee, then 10 centimeters about the lateral aspect of the ankle. So this is the 3 area. After you finish, you apply a little bit of pressure because some patients tend to bleed, especially if they are taking blood thinners. So they tend to bleed. So you apply a little bit of pressure, then put a bandage, and you tell the patient that they need to keep the bandage clean and dry for 24 hours. After that, you can use what we call antimicrobial antibiotic ointment, or sometimes people use Neosporin, which is the same thing, but there are many others. You can find that over the counter in any pharmacy for a few days. In case it's just to prevent infection, which is extremely unlikely, but certainly possible. If you like this video, don't forget to subscribe to my channel and like the video and share. See you soon.